Hi, I am Dr. Trilochan Satpathy, and today I will be discussing with you about an interesting and learning episode of B.Pharma on the unit of chemotherapy, which is an important unit of the pharmacology 3. The goal of this discussion is to provide the details about the different poisoning with their pharmacological treatment. Let's start our episode related to Module 1 to Module 1. Definition of poison. General principle of treatment of poisoning. Module 2. Treatment of poisoning with reference to barbiturates and opiates. Module 1. Definition of poison. General principle of treatment of poisoning. Poison. Poisons are the substances administered either by mouth, injection and inhalation or through skin or mucous membrane which endanger life by severely affecting one or more vital functions. Not only drugs, but other household and industrial chemicals, insecticides, etc. are frequently involved in poisoning. Poisoning may result from large doses of drugs because it is the dose which distinguishes a drug from a poison. Specific antidotes such as receptor antagonist, chelating agents or specific antibodies are available for the treatment of few new poisons. Poisoning could be accidental, occupational, suicidal or criminal. Generally, self-medication is an important cause of drug poisoning and is particularly seen with over-the-counter drugs. In law, a substance given for a purpose of life-saving is a medicine and to produce harm to the body is a poison. These are governed by Poison Act 1919. Types of poisoning. The poisoning in human beings is of two types. 1. Acute poisoning. Secondly, chronic poisoning. Acute poisoning. The symptoms of acute poisoning appear immediately after the ingestion of poison. They increase in severity and may follow death. The poison can be detected in the ingested substance or vomit, stool and urine of the victim. The main symptoms include vomiting, diarrhea, convulsions and coma, that is heavy metals, insecticides. Coming to chronic poisoning, the symptoms of chronic poisoning appear gradually. The symptoms may disappear after removal of a victim from his surrounding. Poison can be detected in the ingested substance or stool, vomit and urine of the victim. The main symptoms are chronic ill health malaise, repeated attacks of gastrointestinal irritation and increased cachexia, that is narcotics, barbiturates, etc. General principle of treatment of poisoning. The general principle of treatment of poisoning cases are: point 1. Stabilization. This includes assessment and management of airway and breathing, circulation and depression of the central nervous system. Point 2. Evaluation, if the patient is already stable. Point 3. Decontamination, including skin or eye decontamination, gut evacuation, etc. Point 4. Poison elimination, alteration of urine pH and diuresis, peritoneal or hemodialysis, hemoperfusion, etc. Point 5. Antidote administration. Point 6. Nursing and psychiatric care. Gastric decontamination. Interference with absorption of ingested poison from the gastrointestinal tract is the mainstay of poison management, because few specific antidotes are available to treat poisonings absorption prevention, observation and supportive care are the clinician's greatest assets. The challenge for clinicians managing poisoned patients is to identify those who are most at risk of developing serious complications and who might potentially benefit from gastrointestinal decontamination. Table 1. Summary of recommendation. Treatment: gastric lavage. Indication: should not be considered unless a patient has ingested a potentially life-threatening amount of poison and the procedure can be undertaken within 60 minutes of ingestion. Treatment: activated charcoal. Indication: may be considered if a patient has ingested a potentially toxic amount of poison up to 1 hour previously. There are insufficient data to support or to exclude its use after 1 hour of ingestion. Treatment of ipecacuanha. Its routinely administration in the emergency department should be abandoned. There are sufficient data to support or to exclude its administration soon after ingestion. Whole bowel irrigation may be considered for potentially toxic ingestion of sustained release or enteric-coated drugs. Cathartics. The administration of cathartic alone has no role in the treatment of poisoned patient and is to recommended as a method of gut decontamination. Gastric lavage. Stomach emptying by gastric aspiration and lavage has been in use in the management of poisoning by ingestion for almost 200 years. Studies as early as 1959 have demonstrated that gastric lavage is no more effective than ipecac emesis induced in the specific instance. The effectiveness of both gastric lavage and ipecac in removing stomach contents is time dependent and best results are obtained when performed within 1 hour. Unfortunately, many overdose patients do not arrive to the emergency department within this valuable 1 hour. Although emptying the stomach in the first hour generally works and may be beneficial for up to a certain period of time, thereafter it is usually not helpful beyond 4 hours of ingestion. Gastric lavage carries potential complications including aspiration, pneumonitis and rarely esophageal perforation. It can also promote the rapid passage of tablets into the small bowel rather than removing them. Studies have now shown that gastric lavage did not prove any more beneficial than activated charcoal alone. Activated charcoal. Activated charcoal has been used in the treatment of poisoning since a long time. In addition to the direct intraluminal binding, activated charcoal can also decrease the reabsorption of agents that undergo enterohepatic and enterogastric cycling. It also has a gastrointestinal dialysis effect, whereby the charcoal serves as a large sink with movements of toxin molecules across semi-permeable membranes from splanchnic circulation. During the last decades, however, activated charcoal became increasingly popular as a first-line agent for the treatment of poisonings, particularly if more than several hours have passed since ingestion. It is generally considered ineffective against caustics, ethanols, ethylene glycol, methanol, iron, lithium, metals and petroleum distillates. Usually complications of its use are rare, but they include aspiration of activated charcoal and gastric contents as well as intestinal obstruction, particularly when repeated doses of activated charcoal are given. The use of multiple dose activated charcoal is now recommended for the clearance of drugs such as carbamazepine, digitoxin, glutathione, nadolol, phenobarbital, phenylbutazone, theophylline and others. Multiple dosing appears to decrease both the absorption and blood concentration of many drugs. The multiple dose regimen consists of an initial dose of 50 to 100 gram followed by maintenance dose of 30 to 50 gram every 2 to 6 hours with or without the administration of a cathartic agent. Maintaining a constant amount of activated charcoal in the gut absorbs the toxin as it is secreted back into the gut, thereby preventing a delayed peak in the serum concentration. When activated charcoal is continually present in the gut, it might act as a infinite sink, keeping the level of the toxin low in the lumen of the gastrointestinal tract. As most of the drugs and toxins are absorbed by simple diffusion, this sink may reverse the normal gradient and actually permit transit of the toxin out of the blood. This has been shown to occur with the theophylline, carbamazepine, dapsone, quinine and phenobarbital. Table 2. Charcoal and multiple dose activated charcoal. Substance not readily absorbed to activated charcoal are ferrous salts, acids, lithium preparations, alkalis, potassium salts, chlorides, ethanol, organic solvents, methanol, mercury and its salts, ethylene glycol, lead and its salts. Indications for multiple dose activated charcoal are slow release preparations such as theophylline but not lithium, carbamazepine, dapsone, digoxin, phenobarbital and quinine. Cathartics. Catharsis actually means purification, and this is achieved in the poisoning cases by purging the gastrointestinal tract of all the poisonous material. This is the premise that promotes their use for the rectal evacuation of gastric contents, both the drug and the drug charcoal complex. The most commonly used cathartics are magnesium sulfate, magnesium citrate and sorbitol. Sorbitol works the most quickly, causing bowel movements within 1 hour. Contraindications to cathartics include caustic ingestions and signs of intestinal obstruction. If being considered, 1 dose is generally sufficient. Whole bowel irrigation. Whole bowel irrigation cleanses the bowel by enteral administration of large amounts of an osmotically balanced polyethylene glycol electrolyte solution, which induces a liquid stool. Whole bowel irrigation has the potential to reduce the drug absorption by decontaminating the entire gastrointestinal tract by physically expelling intraluminal contents. The concentration of polyethylene glycol and electrolytes in the polyethylene glycol electrolyte solution causes no net absorption or secretion of ions, so no significant changes in water or electrolyte balance occur. The procedure has been advocated for overdoses of agents such as iron, lithium, arsenic, lead oxide and enteric coated or sustained release medications. Adults should be given in the solution at the rate of 2 liters per hour, children at 500 ml per hour, either orally or through a nasogastric tube. Coming to emesis, ipecac syrup has long been used as a first line agent for the prevention of toxicity from ingested poisons, especially in children. However, this is not freely available in our country and its effectiveness in recovering ingested substance is poor, and its ability to reduce the severity of poisoning has never been demonstrated. Moreover, the emesis induced by ipecac may preclude the use of other oral treatment options. It is contraindicated in the ingestion of caustic substances and volatile hydrocarbons in patients who have decreased gag reflex or altered mental status, and in patients at risk for rapid alteration in consciousness. Complications of ipecac include aspiration, pneumonia, lethargy, diaphragmatic rupture, malarious, esophageal tears and cerebral hemorrhages. Ipecac is also still recommended by poison control centers for use in the home, where yearly administration can be assured. Rational use of antidotes. Antidotes are chemical or physiological antagonists that prevent the toxicological effect of specific poisons. In most toxicological emergencies, effective antidotes are not available. Symptomatic treatment and supportive care are still the primary approach to treatment. Antidotal therapy often plays a relatively minor role. When appropriately used in specific situations, however, antidotes can substantially reduce morbidity and mortality in the poisoned patients. Poison elimination. Techniques for eliminating the poisons have an important role when applicable. Alteration of urine pH and diuresis. It is useful to alter the pH of the glomerular filtrate such as a drug that is weak electrolyte will ionize, become pure lipid soluble and remain in the renal tubular fluid and leave the body in the urine. Maintenance of good urine flow helps this process, but alteration of tubular fluid pH is the important determinant. The practice of forcing diuresis with furosemide and large volumes of intravenous fluid does not add significantly to drug clearance, but may cause fluid overload. It is obsolete. Alkalinization may be used for salicylates greater than 500 mg per liter plus metabolic acidosis or increase greater than 750 mg per liter. Phenobarbital 75 to 150 mg per liter. The objective is to maintain a urine pH of 7.5 to 8.5 by an intravenous infusion of sodium bicarbonate. Hemodialysis. The system requires a temporary extracorporeal circulation, that is from an artery to a vein in the arm. A semi-permeable membrane separates blood from dialysis fluid. The poison passes passively from the blood where it is present in the higher concentration to enter the dialysis fluid, which is flowing and constantly replaced. Hemodialysis significantly increases the elimination of salicylates, isopropanol, lithium, methanol, ethylene glycol and ethanol. Hemofiltration. An extracorporeal circulation brings blood into the contact with highly permeable membrane. Water is lost by ultrafiltration and solutes by convection. The main change in plasma concentrations results from replacement of ultrafiltrate with an appropriate solution. Hemofiltration is effective for phenobarbital and other barbiturates, glutathione, meprobamate, theophylline, methaqualone, etc. General measures. The initial clinical review should include a search for known toxic syndromes as follows. Maintenance of an adequate oxygen supply is the first priority and the airway must be sucked clear or oropharyngeal secretions or regurgitated matter. External cardiac compression may be necessary and should be continued until the cardiac output is self-sustaining, which may be a long time when a patient is hypothermic or poisoned with a cardiodepressant drug, that is tricyclic antidepressant, beta adenoceptor blocker. Investigation includes biochemical screening of plasma for commonly used agents, that is paracetamol, and measurement of plasma electrolytes. Module 2. Treatment of poisoning with reference to barbiturates and opioid. General principle and treatment of different poisonings. Barbiturate poisoning. Barbiturates may be classified as long-acting such as mephobarbital, barbital, phenobarbital, pyrimidine, etc. or short-acting such as amobarbital, butabarbital, phenobarbital, etc. Barbiturates are well absorbed from the stomach and the intestine. Barbiturate poisoning may be occurring mostly suicidal, sometimes accidental, infrequently encountered now due to inavailability of barbiturates. Principle. The principle of treatment applies to any central nervous system depressant poisoning. Manifestations are due to excessive central nervous system depression. Patient is flabby and comatose, which swallow and failing respiration, fall in blood pressure and cardiovascular collapse, renal shutdown, pulmonary complications, bolus, erosions. Lethal dose depends upon lipid solubility. It is 2 to 3 gram for the more lipid soluble agents, short acting barbiturates, and 5 to 10 gram for less lipid soluble phenobarbital. Treatment. First treatment is gastric lavage. Leave a suspension of activated charcoal in the stomach to prevent absorption of the drugs from intestines. Second, supportive measures such as airway assisted respiration, oxygen maintenance of blood volume by fluid infusion, and use of vasopressors. Dopamine may be preferred for its renal vasodilating action. Point 3. Alkaline diuresis with sodium bicarbonate 1 milliequivalent per kg intravenous with or without mannitol is helpful only in the case of long acting barbiturates which are eliminated primarily by renal excretion. Point 4. Hemodialysis and hemoperfusion through a column of activated charcoal or other absorbents is highly effective in removing long acting as well as short acting barbiturates. There is no specific antidote for barbiturates. In the past, analeptics like methanol, bemegride, etc. have been used in an attempt to awaken the patient. Opioid poisoning. Opioids may be consumed in large doses or in attempted suicide. Inadvertently by an addict, opium is obtained by incision of the unripe fruit of a poppy plant called Papaver somniferum. Principle. Opioids rapidly assess the vital signs, maintain an airway, assure ventilation. There is a danger of underestimating the severity of respiratory depression. Administer oxygen by nasal cannula, face mask or endotracheal tube. Ensure intravenous access. Infuse isotonic glucose solution. Monitor the electrocardiogram. Over-enthusiastic administration of the specific antidote naloxone can be provoke acute withdrawal in those habituated to opioids, and this can complicate treatment. Naloxone is a competitive antagonist. It is relatively ineffective in treating poison by partial agonist, particularly buprenorphine. Careful titration of the dose of antidote administered should allow the treatment of respiratory depression, assuring a respiratory rate above 14 breaths per minute without provoking acute withdrawal treatment. Naloxone 0.4 mg, 0.01 mg per kg body weight intramuscular or intravenous should be given immediately and repeated in 3 to 10 minutes if there is no improvement. Point 2. The effect of naloxone decreases within 2 to 3 hours, and it is therefore essential that a patient is monitored for at least 24 hours if heroin overdose is suspected, or for 72 hours if methadone or similar long active opioids overdose is suspected. Point 3. Maintenance of respiration, intravenous fluids and pressure agents to maintain blood pressure should be administered. Gastric lavage is done to remove any unabsorbed drug. Point 4. Cardiac arrhythmias and convulsions are seen with codeine, propoxyphene or meperidine and should be appropriately treated. Point 5. Addicts usually manifest withdrawal symptoms within one course of administration of naloxone. Aggressive correction of withdrawal symptoms should not be undertaken until the patient's vital signs are stable. Fatal dose: morphine 200 mg.